we're going to be having two curriculum topics. The first one is Management of Advanced Heart Failure Device Therapy by Dr. Charles Corey. So we start now. Dr. Corey, over to you, sir. Thank you.
Okay, good evening, everybody. So our topic for today is management of advanced heart failure. Okay, so I'm just here to talk about the devices used, okay, for management. All right, so let me just start. So like we all know, heart failure is a common clinical syndrome in which symptoms result from. Please, are you hearing me very well? Let me be sure.
Yes, we can hear you, but of course, if your volume can go higher, we'll appreciate it. Thank you.
Okay, let me speak loud. So heart failure is a common clinical syndrome in which symptoms result from a structural or functional cardiac disorder that impairs the ability of the ventricle to either fill or eject blood. So like we all know, there are many causes of heart failure: disease of the myocardium, pericardium, endocardial valve disease, coronary artery disease, or disease of the vessels, or even metabolic disorders, all can cause heart failure. Okay. Also, like we all know that heart failure, ventricular dysfunction, is characterized according to rejection into heart failure with reduced ejection fraction, with EF of less than or equal to 40%. This was previously known as systolic heart failure. Then also heart failure with preserved ejection fraction, EF greater than or equal to 50%. Okay. Also previously referred to as diastolic heart failure. Now we also have recently introduced heart failure with mid-range ejection fraction, where the EF is 41 to 49%. But of course, we know that most of the
Mommy what she want. Mommy will do what she want.
okay. Okay, so we all know that most of the studies have been done with heart failure with reduced ejection fraction. That has been more studied, and it's the same thing for devices. Most of the devices have been proven to work with heart failure with reduced ejection fraction. More devices that for heart failure with preserved ejection fraction are still studied, and most of them have not gotten, or majority of them have not gotten approval, FDA approval. Okay, so of course, we know that advanced heart failure occurs when patients with heart failure experience persistent severe symptoms that interfere with their daily life, despite maximum tolerated evidence-based medical therapy. So it's been seen that as heart failure patients, of course, without treatment, most heart failure patients will die. Heart failure has a 50% mortality in 5 years. Okay, but despite treatment, if you notice that as the disease goes on, it still continues to progress. Okay, despite sometimes even the patient being on optimal medical therapy or guideline medical therapy doesn't still stop it. So these patients have been described as having refractory heart failure or end-stage heart failure, or if you use the ACC classification, they are in stage D heart failure. Okay, so I just wanted us to revise the ACC stage. I just wanted to revise the ACC staging of heart failure, where stage A is at high risk for heart failure, but without structural heart disease or symptoms of heart failure. Stage B is where you have structural heart disease, but the patient doesn't have any signs or symptoms of heart failure. Okay, so this includes patients in NYHA1 with either no present symptoms or prior symptoms of heart failure. Okay, so stage C is now where there is structural heart disease with prior or present symptoms of heart failure. Okay, so this includes patients in any functional, any other NYHA class that has symptoms. Okay, then stage D is when heart failure has become refractory. So in stage D, they require specialized interventions Okay, so most of the patients, they require specialized interventions. Most of them will be in NYHA 4. Okay. So it's always important to note that medical therapy, although what we are doing is actually, because most of these devices are medical too, but by medical therapy, I mean pharmacologic therapy. Okay, guideline-directed pharmacologic therapy must be optimized before considering additional devices, except there are situations where there are specific indications, okay, even if GDMT has not been fully optimized. Okay, so the first device I'll talk about is the ICD. As a background to the ICD, I want to say that for heart failure, most of the patients with heart failure will die from two things. Okay, they will die from two things. Number one is die from progressive pump failure. Progressive pump failure means that, especially those with low ejection fraction, will sign the ability of the pump action of the heart or the LV becomes so markedly. Okay, so no, that's the first thing they will either they die from progressive pump failure, or number two, they die from arrhythmic events. Okay, so they can die from sudden onset, sudden arrhythmia, especially ventricular arrhythmias. Okay, now most of the patients it has been noted from studies that most of the patients in class in 4 in NYHA, especially those who may become, who may become dependent on inotropes. Okay, even abroad, they give inotropes at home and all that. Tell those who become dependent on inotropes. Most of them in 4 will actually die from pump failure. But many of the patients in NYHA 2 and 3, it's been noted that most times it's not progressive pump failure that kills them. They usually die from sudden events. Okay, sudden, especially ventricular arrhythmias. Okay, and these deaths are usually sudden and unexpected. Okay, just hear that a patient with heart failure was about to be discharged. By the time you come the next morning, you see that the person is gone. He had a cardiac arrest and couldn't be resuscitated. And from there, he died. So we see a lot of this. Okay, so most of these are due to electrical disturbances, which many of them are ventricular arrhythmias. Okay, so what the ICD does is that the ICD they're effective at correcting potentially lethal ventricular arrhythmias. And ICDs have been proven is a lifesaver because it has been proven to improve mortality, okay, in patients with heart failure. So I will go through, this is the ESC 2021 guidelines of showing the recommendations for ICDs in patients with heart failure. So an ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability, who are expected to survive for more than 1 year with good functional status in the absence of reversible causes, or unless the ventricular arrhythmia has occurred less than 48 hours after an MI. So what this point is trying to say that this is for secondary prevention. So patients who have survived, so whenever we are asked indications for ICD, the first indication we say is secondary prevention. Patients who have survived an arrest. So maybe they had an arrest, they were resuscitated, and they came back. They must have an ICD. Okay, so this is to reduce the risk of sudden death in patients who have recovered from a significant ventricular arrhythmia, even if they didn't have an arrest. But if they had an arrhythmia that caused hemodynamic instability, okay, they qualify for ICD, so long as they are expected to survive for more than 1 year. So most of these patients will be in NYHA class 2 or NYHA class 3. Okay, so long as they are expected to survive for 1 year with good functional status. Good functional status indicates that they are not, they don't have maybe malignancy that will kill them in less than 1 year and all that. Good functional status also indicates that this also indicates that the cause of the arrhythmia is not a reversible cause, maybe an electrolyte imbalance or whatever. It's a reversible cause. The treatment is to correct the reversible cause, not to put an ICD. Okay, now in the case of MI, if the arrhythmia has occurred less than 48 hours after an MI, of course, you want to be sure that it's not the acute MI that is predisposing to the arrhythmia. That is the essence for waiting. So this is for secondary prevention. Now, for primary prevention, ICDs are recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure. Anyway, that's, you see, this one is now NYHA class 2 or 3, okay, of an ischemic etiology, unless they have had an MI in the previous 40 days. So now, with this now, for primary prevention, the indications are: number 1, patient must be in NYHA class 2 or 3. Number 2, the ejection fraction must be less than or equal to 35%, despite 3 or more months of guideline-directed optimal medical therapy, okay? Then also, they must be expected to survive substantially longer than 1 year with good functional status, just like we talked about in the previous class. So this is a class 1 recommendation. So these are the only class 1 recommendations for ICDs. Okay, let me take this one again because it's actually very important. Okay, patients who have symptomatic heart failure, that they are symptomatic despite being on guideline-directed optimal medical therapy, then NYHA class 2 or 3, ejection fraction less than or equal to 35%, despite 3 or more months of guideline-directed optimal medical therapy. Now, if the heart failure is due to an ischemic cause, you have to wait for 40 days, okay, because of course, immediately following ischemia, the ejection fraction may be low, okay, but maybe with revascularization or even with remodeling and all that, after 40 days, it may improve. So you need to wait for 40 days to be sure that the person merits or warrants, or the indication warrants putting an ICD. So these are class 1 indications. Okay. Now, other indications include like other class 2, not indications, recommendations. Class 2 recommendations says that ICD should be considered to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of a non-ischemic etiology and ejection fraction less than or equal to 35%, despite 3 or more months of optimal medical therapy, provided that they are expected to survive substantially longer than 1 year with good functional status. Okay, so this one is talking about if the etiology is now non-ischemic, okay? Then, of course, other recommendations in the guidelines say that patients should be carefully evaluated by cardiologists before generator replacement, okay? Because clinical statins may change. So, of course, it's the cardiologist that will select the patients and all that. Okay, there's also room for a wearable ICD heart failure who are at risk of sudden cardiac death. So if you put a device inside, there are other superficial ICD. This is a class 2B that can be used temporarily. Okay, so then class 3, okay, which means that class 3 should not be done. Okay, or if they are done, they may harm the patient. So like I said, it's not recommended within 40 days of an MI. At this time, studies have shown that it does not improve prognosis. Okay, so if the patient is NYHA class 4, ICDs are not recommended if the symptoms are severe and refractory. Okay, so unless you should do other things, the teaching is that you should do other things first. You should either consider a CRT, consider an assist device. Those things we'll still talk about them. Okay, or refer for transplant before considering an ICD if the patient is in NYHA class 4. Okay. The next device I'll talk about is cardiac resynchronization. Okay, cardiac resynchronization is one of the things that has revolutionized heart failure management in the last 20 years. Okay, the simplest way to understand CRT is to know that it is biventricular pacing. Okay, so both the left and the right is paced, multimodality pacing. Okay, why this biventricular pacing is important is that in heart failure with reduced ejection fraction, one of the most important things that happen is called the synchrony. The synchrony means that both walls of the ventricle are not contracting at the same time. Okay, so because of that, the ejection fraction becomes worse. It becomes markedly reduced. It tends to get worse and worse and worse and worse. Okay, so what the CRT tends to do is it wants to pace both sides, okay, both RV and LV pacing, okay, to enhance contractility. Okay, now there are many ways that CRT can be done in this time and age. There can be a CRTP. CRTP is like a CRT with a pacemaker. Okay, that's a combined CRT. That's just to pace both ventricles. Okay, that's a CRTP. Okay, there's also a CRTD. Okay, CRTD. That CRTD is cardiovascular defibrillator. That's you combine a CRT and an ICD. Okay, so what happens is that the device includes a transvenous pacing lead that is placed in a branch of the coronary sinus. Okay, for LV pacing. Then the second lead is now placed in the RV apex, okay, or the right atrium. So these leads are now attached to a pulse generator that is now typically located where pacemakers are located in the subcutaneous tissue of the upper chest. It's important to say here that CRTs have made dramatic improvement in the treatment of most patients with heart failure. And of course, if the patients qualify, because CRTs also have their own drawbacks, okay, which I will talk about. Okay, but for patients that qualify and patients that respond, CRTs have shown to improve mortality, okay, and also reduce hospitalization. Okay, and it does this, like I said, by restoring mechanical synchrony, by electrically activating the heart in a synchronized manner. Okay. Now, it's also important to say here that the QRS duration is one of the most important markers in determining who and who will benefit from a CRT. It has been shown from studies that patients benefit maximally with QRS duration of 150 millisecond with a left bundle branch block pattern. So they benefit maximally with a QRS duration of 150 millisecond with a left bundle branch block pattern. Okay, so it's important that all those things are in place, okay, before referring patients for CRT. Okay, so two landmark trials. Oh, this is not my updated slide. I actually updated the slides today. Okay, but I'll just talk about it. Two landmark trials: the companion trial in 2004 and the care heart failure trial in 2005. Were the trials. I believe it's important that we know that we know about the companion trial in 2004 and the care heart failure trial in 2005. Okay, these two trials established the benefit of CRT in terms of hospitalization and improved survival. But what the companion trial did is to group the patients into three. The companion trial grouped the patients into patients who received optimal medical therapy, patients who received CRT PACE, and patients who received CRT-D. That's a combined CRT and an ICD. So it was and these patients were now followed up over time. I'm not sure how long, I can't remember how long, but it was said that patients who had a CRT-D had improved survival, less hospitalization, more than those who had CRT-P, and more than those who had just optimal medical therapy, that's guideline-directed medical therapy, as at that time. Okay. The care heart failure trial also established similar benefits. Okay, but this time around, the care heart failure trial just used CRTP and optimal medical therapy, and of course, they noted improved mortality among those patients who had a CRT. Okay, so this is the ESC 2021 guidelines for use of CRT, where class 1 recommendation is that CRT is recommended for symptomatic patients with heart failure in sinus rhythm with a QRS duration of more than or equal to 150 milliseconds. Please, let's note the following. Number one, patients are symptomatic. Okay, heart failure patients who are symptomatic. Number two, the patients are in sinus rhythm. Okay, the reason why sinus rhythm is important is because it is difficult to actually, for example, now patients with AFib, okay, the AFib is irregular. So the source of the irregularity is coming from the atrium. Okay, so in patients with AFib, CRT is still, how will I put it? It's still controversial even up till today. They are like, because it has not been shown, patients who have AFib and get CRT have not been shown Okay, that's also very important. Number 3, left bundle branch morphology. Okay, so apart from more than 140, it has been seen that the patients with LBB morphology benefits most, and the patients with RBB morphology do not really, even if the QRS is more than 150, but they don't have LBB, they have RBB, they don't benefit as much. Why patients with like interventricular conduction block, okay, who neither have LB or RBBB, their benefit is somewhere in the middle, okay, but patients with LBBB benefit maximally. So that is also very important, okay, and these are all the criteria that must be there, and the patient must have been on optimal medical therapy, okay. So the patient is on optimal medical therapy, still symptomatic, okay, patient in heart failure with sinus rhythm, with QRS duration more than 150 milliseconds, LBB morphology, and severe LV ejection fraction, severe LV systolic dysfunction less than or equal to 35%, okay. All right, so that's the class 1 recommendation, okay. So now if a patient now has need for pacing, okay, now this is also a class 1 recommendation. If a patient now has need for pacing, maybe patient has a AV block, complete heart block, whatever, and has a need for pacing in order to reduce morbidity, okay, that patient, if a patient in heart failure has a need for pacing, okay, now because of the need for pacing, that patient should get a CRT. So you don't just put a pacemaker, patient should get a CRT. This one also includes patients with atrial fibrillation. Patient with atrial fibrillation can also have complete heart block. They have atrial fibrillation with complete heart block, atrial fibrillation with high-grade AV block. So if there's a need for pacing because of whatever the indication, okay, and the patient now has heart failure, LV ejection fraction less than 35, that patient should get a CRT. This is also a class 1 indication that we should also remember. Okay, now for class 2, so we've talked about class 1 indications. There are 2 class 1 indications, okay. The first one is, we've talked about it, and so class 2 indications include symptomatic patients in sinus rhythm with a QRS duration more than 150, more than or equal to 150, now with a non-LBB QRS morphology. So patients with a maybe they have an interventricular conduction block pattern or so these ones are a class 2A indication. Okay, so also under class 2 indication is that CRT should be considered for symptomatic patients with heart failure and sinus rhythm with a QRS duration of 130 to 149. So it's not up to 150, 130 to 149 with LBB morphology, okay, and EF less than 35% despite optimal medical therapy in order to improve symptoms and reduce morbidity. Okay, these ones may not benefit as much as those with 150. That's why it's a class 2A indication, okay. So patients with LV ejection fraction less than 30. So this other indication is for patients who have severe LV systolic dysfunction, okay, and they have received a pacemaker and ICD for whatever the reason in the past, okay. Now, and this patient, despite whatever they have, they now develop worsening heart failure despite optimal medical therapy. Okay, so this patient should be considered for an upgrade. So you should consider upgrading their device. Maybe they had an ICD. Okay, you should consider upgrading their device to because they already have a device. So this is also a class 2A. This is also a class 2A indication. Okay, so class 2B indication says that CRT may be considered for symptomatic patients with heart failure and sinus rhythm with a QRS duration of 130 to 149 milliseconds and non-LBB QRS morphology with LV ejection fraction less than or equal to 35% despite optimal medical therapy in order to improve symptoms and reduce mobility and mortality. Okay, so CRT is not recommended in this is a class 3. It should not be done because it may not have benefits or may even be harmful. CRT is not recommended in patients with QRS duration less than 130 who do not have an indication for pacing. If they have an indication for pacing, it becomes a class 1, like we talked about. So you put a CRT. Okay, so if they do not have an indication for pacing, CRT is not recommended in patients with QRS duration less than wanted. Now, what are the contraindications to CRT? Well, there's no formal contraindication. Different places said different things, but this is what I concluded to take, that there's no absolute contraindication for CRT because it all depends on looking at the patients as they come, taking the patients, individualizing the patients, okay? Because many times you are considering different things. You are considering the etiology of the heart failure, you are considering the ejection fraction, you are considering the symptomatology, you are considering other devices and other comorbidities that the patient has and all that. But there are some things that will make you to be wary, okay? If in a patient, if you want to put a CRT, number one is extensive scarring of the lateral wall, okay? If there's extensive scarring of the lateral wall, okay, this scarring will already hinder the ability for conduction to take place, okay? It will hinder the ability for conduction to take place. Of course, you know why in CRT LBB is important, because if you look at the normal conduction pathway, patients with LBBB, okay, if the left bundle branch is blocked, the current or the impulse goes to the right bundle and from there activates the left side of the heart. So if there's extensive scarring, it will be difficult for you to achieve synchrony despite the presence of a CRT. Okay, I've talked about the presence of a right bundle branch block, although it's not considered, I'm sure, an absolute contraindication. But CRT, the studies have not proven patients who have RBBB to have significant benefits. Okay, uncertainty. Okay, I talked about AFib. Okay, I've talked about AFib. So AFib is one of the also gray areas. Patients with AFib have not been seen to benefit from CRT. Then the final one, patients with acute decompensated heart failure. You want to, of course, bring them out from the heart failure first. Okay, because sometimes after treatment of heart failure, ejection fraction may improve. So when they come out of heart failure, if it doesn't improve, you can now consider CRT. The next device I'll talk about is cardiac contractility modulation device. I should have put a picture of CRT, but maybe I'll add it to the slides and put it. Okay, so cardiac contractility modulation. So this is a device-based therapy. So they've been thinking about if patients cannot benefit from CRT, what else can we use? Okay, what else can we use? So that's how CCM came about. So this is a device-based therapy for heart failure that involves non-excitatory electrical stimulation to the R receptor wall during the myocardial refractory period to augment the strength of. So this one, you want to electrically stimulate the RV septum, okay, to augment subsequent myocardial contraction. Okay, now small clinical trials here and there have suggested that it may improve symptoms, functional capacity, and quality of life, but it has not been shown to have hard clinical outcomes such as hospitalization and mortality. So the benefits of CCM on hospitalization, mortality has not been established, and of course, it's not yet licensed for treatment of heart failure. Okay, but the benefit is seen mostly in those with symptomatic heart failure, symptomatic HFrEF with EF from 25 to 45 and a narrow QRS duration. So you want to use this in patients who have narrow QRS duration, whom CRT is not an option. And of course, you can also combine CCM with an ICD. Okay, but studies are still ongoing and is not currently endorsed by current guidelines, but as time goes on, it may. So this is how the device looks like. So you want to electrically stimulate the RV septum to help to increase contractility. Okay, then I'll go to mechanical circulatory support devices. In patients with heart failure who are refractory to optimal medical and device-based therapy, long-term mechanical circulatory support devices with a ventricular assist device, that's the more common one, or an artificial heart may be an option. So these devices have been shown to reduce the risk of death and improve quality of life. Okay, of course, course, this device to patients who are able to manage themselves, who are compliant and all that, who are able to manage residual heart failure symptoms, who are able to be literate enough to safely operate the device and prevent and treat common complications. Okay, and know when to prevent to the hospital. I'll still talk about the complications. So there are two major types of mechanical circulatory support devices. They include the ventricular assist device and the artificial heart. Okay, so these devices want to prolong survival, improve quality of life in patients with advanced heart failure, okay? And in patients who are eligible for heart transplantation, you want to maintain organ function until transplantation can be performed, okay? So let me start with the first one, ventricular assist devices. These are surgically implanted mechanical circulatory support devices that is intended for use outside the hospital. So there are devices that can be used inside the hospital. For example, the ECMO, okay, but these VADs are intended for use outside the hospital. Okay, and the purpose is to support patients with heart failure by increasing perfusion and reducing the filling pressures in the heart. Okay, so they assist the pumping action of the diseased ventricle. So what they do is to help the diseased ventricle to actually fill and pump out blood. Okay, so it's ventricular assist devices augments but does not completely replace the function of the heart. So they are described as having an inlet cannula. So they have like a cannula where blood is directed from the left ventricle into an electrical motor. Okay, the motor is what pumps blood into the aorta via a flexible outflow graft. Okay, so it's like blood leaves from the LV into a cannula, goes to the motor, and from there it's connected into the aorta through this graft. Okay, so the motor, of course, receives power via an insulated cable that is tunneled into the skin to an external controller that is connected to batteries. Okay, the patient and the caregiver team are now able to use the controller to receive basic information about the pump settings. Okay, they can be able to change the pump settings, check the power consumption, and of course, change the battery when the batteries are going down. The controller also has the ability to generate alarms such as low battery and other abnormalities that may require the attention of the patient or the caregiver. So what are the indications for LVAD? LVAD has 4 basic indications. So number 1, it can be a bridge to transplantation. So you have seen the patient will or is being worked up for heart transplantation, but may not be able to survive till the time the patient gets a heart. So this patient will need an LVAD. Okay, it can be a destination therapy. Of course, before this was not in place. Okay, LVAD were mainly used as bridges. Okay, but now LVAD can be destination therapy. Okay, it can also be a bridge to decision. Bridge to decision simply means that you are putting an LVAD until you are certain that the person needs a transplant. Okay, so it can be a bridge to either the final decision of a transplant or final decision of no transplant. Therefore, it now becomes a destination, and it can be a bridge to recovery. Okay, patients who have etiologies that may recover, especially maybe ischemia and all that, it can be a bridge to recovery. Okay, so these are the indications for, of course, for either bridge to transplantation, destination therapy, or bridge to recovery. Okay, and it said that all these indications must be applicable, okay, before the patient qualifies for an LVAD. Okay, number 1, patient must be in NYHA class 4 for 2 to 3 months, for 60 to 90 days. Patient must be on maximally tolerated medical therapy, okay, with either certified respiratory therapy or an ICD if indicated. Okay, the patient must be on, because the first thing you try is inotropes. Okay, the patient must have had either inotropes at home or must be on long-term inotropic therapy, must be chronically dependent on inotropes. Okay, the ejection fraction must be less than 25%. The pulmonary capillary wedge pressure must be greater than or equal to 20 millimeters of mercury. The systolic blood pressure must be less than or equal. So these patients are the people who have cardiogenic shock, isotropic dependence, high pulmonary pressures, high pulmonary pressures, and you are sure that it is left heart disease. Okay, they have low blood pressure with systolic of 80 to 90. Okay, or cardiac index less than or equal to 2 liters per minute per per meter squared, okay? Or they have evidence of declining renal function, they have cardiorenal syndrome, okay? From left heart, they begin to develop RV systolic dysfunction, okay? So those are the patients that qualify for LVAD. So they must, from what I got from this, that patients must be really bad before they qualify for LVAD. Okay, so what are the contraindications to assist devices? Number one, RV systolic dysfunction. Now, this RV, it's important to say that RV systolic dysfunction from primary right heart failure, either lung disease or any other thing that can cause right heart failure. Okay, so RV systolic dysfunction that is not due to, how you know this is actually the pulmonary capillary wedge pressure. Okay, so RV systolic dysfunction that is not due to left heart failure. Okay, so because improper functioning of the right ventricle will lead to insufficient filling of the left heart. Okay, and this will lead to inadequate inflow in the device, and ultimately the device will malfunction. Okay, so it's a contraindication. If there's acute cardiogenic shock with neurologic compromise, okay, so this person has because of cardiogenic shock, is having a watershed stroke or something like that. You don't want to put an LVAD for the person, because even after I put the LVAD, the person will still not likely recover. Okay, if there is severe comorbidity, maybe a severe renal disease, there's CKD, there's interstitial lung disease, there's stroke, or evidence of advanced metastatic cancer that is not treatable, all these things are considered contraindications. Okay, if there is bleeding, active bleeding or thrombocytopenia, okay, with a platelet count less than 50,000, or if there is a confirmed HIT, heparin-induced thrombocytopenia. Okay, also, if the person is not bleeding, but the person cannot take anticoagulation for any cause, okay, because patients who have LVAD must be placed on anticoagulation. If the person cannot take anticoagulation for any reason, is also a contraindication to LVAD. Okay, there are also some anatomical factors that may hinder adequate placement of the LVAD. For example, patients with hypertrophic cardiomyopathy, which we are still going to talk about today, or patients with a large VSD. Patient with a large VSD, you may not be able to adequately place the device. All these things are also contraindication. Okay, technical limitations, people who have low body surface area, okay, it's also a limitation. Then social limitations. Of course, you won't put an LVAD, maybe psychiatric patients, you won't put in patients who cannot comply to anticoagulation, you won't put it in because of the many difficulties. So the patient must be able to operate the device, patient must be able to take instruction, patient and family members must be able to interpret basic functions and alarms. Okay, because any difficulty posed by such factors could actually pose serious harm or danger to the patient. So you need to be sure that all those things are in place before considering putting an LVAD. So this is how an LVAD looks like. The device is the device that is at the apex there, at the tip of the heart, and you can see it is pumping through a graft. It will pump the blood here through a graft that will now go to the aorta. So it's now connected to some external things that will now have like batteries and all that. And you can monitor all of those things that are the things that I think are in the pocket. Okay, so this is the inside. This is the inside of the device, which I have not understood very well, but there's like a there's a fully magnetically levitated centrifugal flow pump, okay, that pumps there. You can see the red arrow on the left, okay, that pumps it there through the outflow graft. From there, it now goes to enter the aorta. Of course, there's an external battery pack, there's a system controller, okay, and there's a place where it enters the skin. The picture on the right tries to show the details, the motor. You can see the inflow cannula that receives blood from the left ventricle, okay, into the motor, which now pumps the blood to the aorta. Okay, so in managing patients with LVAD, long-term management will consist of frequent follow-up to assess for device-related complications and, of course, residual heart failure. These patients must be maintained on lifelong anticoagulation and lifelong antiplatelets. Okay, and of course, self-care such as battery management. How often do you change the batteries and all that? and wound maintenance. Then if there are chronic conditions, they should be comorbidities should be treated appropriately. Then appropriate assessment for heart transplantation if patients which meet the criteria. Sorry for my slides. These slides are too crowded. Okay, so please sincere apologies for that. But what are the complications of assist devices? Number one is hematological complications. Okay, there are many of them. Okay, bleeding is the most common complication. Okay, of course, bleeding can be to various reasons. Number one, anticoagulation. Okay, number two, these patients have impairment of normal clotting mechanism, or they've been shown to have impairment of normal clotting mechanisms, which also they've been also known to develop a high prevalence of acquired von Willebrand's disease. Okay, there could also be bleeding through leaks. If the things are not connected well, there could be leak at the pump side, there could be leaks from the grafts. Okay, they're also prone to gastrointestinal bleeding. They're also prone to intracranial bleeding. Okay, maybe because of anticoagulation. Okay, then the target INR for patients with LVAD is 1.5 to 2.5. Target INR of patients with LVAD is 1.5 to 2.5. Okay, so apart from bleeding, patient may develop, of course, you are undergoing the virtuous triad, okay, because of endothelial injury, okay, hypercoagulability. So of course, they are prone to thrombosis. Thrombosis can lead to embolism, okay, which can lead to stroke, okay. So stroke can be, they are prone to both hemorrhagic, okay, due to anticoagulation, excessive anticoagulation. They're also prone to ischemic stroke due to thrombosis and thromboembolism. Okay, they also have a risk of hemolysis due to technical complications involving the design of the pump. Okay, sometimes as blood passes through that motor, maybe the motor may lyse the blood cells. Okay, especially when the cannula is not well positioned and all that. Okay, because of if they're on anticoagulation, they develop heparin-induced thrombocytopenia. If that is what they are used, that's also one of the. Those are some of the hematological complications. Okay, they're also prone to right heart failure. They're also prone to right heart failure. This is because the increased cardiac output from the LVAD results in an increased venous return to the right ventricle. The right ventricle may not be able to take this improved. It may not be able to take this more work because it has been used as load. Okay, this can now result in right ventricular failure. Of course, infections can occur. Infections can occur at the pump site. Infections can occur at the pump pocket. Infections can occur. The drive line simply refers to the tubing, either the inlet cannula or the outflow gas. Infections can also occur at the drive line. Okay, so they will present with localized warmth, erythema, just features of inflammation. Okay, together with fever and leukocytosis. The commonest organism that causes this is Staph aureus, but other organisms include Enterococcus and other staphylococcal species. The commonest gram-negative organism is Pseudomonas aeruginosa. So infections should be aggressively treated with use of appropriate antibiotics. Sometimes you may need to surgically reverse the drive line, you may need to change it and all that. The pump may need to be replaced if the infection is deep seated. Okay, there may also be surgical. They may need for surgical debridement. Okay, so severe infections may want you removing the device entirely and expediting ECMO or cardiac transplantation. Okay, so what about some neurological complications? They may have stroke, both ischemic and hemorrhagic. Okay, I've talked about the reasons for both ischemic and hemorrhagic. They're also prone to arrhythmias. Ventricular arrhythmias are very common after the procedure. Of course, you're placing a cannula. The cannula is directly in contact with the LV. So you are stimulating the heart. That alone can cause ventral circuit that may lead to different sorts of ventricular arrhythmias. Even the suctioning effect of the cannula as it's trying to suck out blood from the LV, okay, can also trigger arrhythmias. Okay, normally these arrhythmias can be, you can manage it by either reducing the setting, maybe reducing the speed of the withdrawal of blood and all that. You can also manage it medically using our antiarrhythmics, okay? Refractory cases may require catheter ablation or exchange of the device. Okay, so the next thing I'll talk about for the mechanical circulatory support devices are what is called artificial hearts. Okay, So artificial hearts are surgically implanted mechanical circulatory support devices that are used to treat refractory heart failure, which are not amenable to treatment with a VAD, okay, the ventricular assist device. So what it does is to treat patients with heart failure by increasing cardiac output and reducing the cardiac filling pressure. Okay, so in contrast to a VAD, which augments, the assist device actually takes over. So the artificial heart, actually takes over the pumping ability of the heart. So it does what the heart should do, actually. So it does the pumping. Okay. Compared to assist device, artificial hearts are not frequently, they are not used frequently. I'm not certain if it's in the guidelines, okay, unlike the assist device. Okay, so they are not used frequently. So what is done is that one ventricle is connected between the vena cava and the pulmonary artery to pump blood to the pulmonary circulation, while the other ventricle is connected between the pulmonary veins and the aorta to pump blood. So it's totally bypassing the effect of the heart, okay? So the most commonly used artificial heart rapidly shuttles air in and out of a polymer bladder contained inside the ventricles, and this action creates a systolic pumping action and a diastolic suction effect. So this air travels to and from the patient via large pneumatic tubes that tunnel through the skin to an external unit that contains a pneumatic pump, batteries, and the controller. The controller monitors the function of the pump. It displays battery power and certain information. Okay, so this is just entirely what it does is just to take over the function of the heart. This is how an artificial heart looks like: one for the left ventricle, one for the right ventricle, pumping blood to the pulmonary circulation. The one on the right is pumping blood. You can see it's pumping into the aorta. Okay, this is the picture I could find. So this is where I end my presentation. Like we all know, the approach to management of advanced heart failure includes most of our patients will not need devices. That's the truth. Most of our patients will need primary care, will need guideline-directed medical therapy. They will need non-pharmacological care. They will need the Fantastic Four. Okay, they will need the Fantastic Four, which are ANI, the SGLT2 inhibitors, aldosterone antagonists, and the beta blockers. Okay, so it's important to say that is actually the first thing before we talk about all these devices. But devices must be used. We must learn to refer patients for these devices when they are indicated and when they meet the criteria. Thank you very much for your time. Thank you for listening.
Wow, Dr. Okori, thank you so much for a comprehensive discussion. But before we go ahead, we recognize the presence of all of our chiefs tonight. Professor Oladimeji, Dr. Kweki, Dr. Popi. I think I saw Dr. EJ too earlier. Good evening, sirs.
Good evening, Adeyanju. Well done.
Chief, it's good to see you and hear you too, sir.
Thank you so much. Thank you for holding on and all the commitment.
Yes, sir. Chief Okopi, Prof, sir.
All right, thank you so much, Adeyanju. Okay, Prof, sorry.
No, continue, Chief. Continue. Thank you.
All right, thank you so much, Dr. Adeyanju. Thank you, Dr. Charles Okori, for the effort you invested in making this presentation very clear and concise. Thank you so much. I think it's time for us to make contributions before we call on coordinators and chiefs. So those going for exam, please, if you want to ask questions and contribution. Just the way I said, we took advanced heart failure and device management. By tomorrow or next, Dr. Namanu will take heart transplant. So these 2-3 topics in our own exam, they constituted about 15 questions towards the end, from 175 to this discussion. So please, if you want to make any contribution or ask questions, do follow on the other fellows. Before we start, let me recognize special presence of Dr. Kweki. Dr. Kweki, it's nice to have you. I believe where you're working now, you have a lot to say about this particular presentation. We have Dr. EG, and Dr. EG He has traveled wide and far. So in his imagination too, he has a lot to say. We have Dr. Chuka. Dr. Chuka was a vibrant man towards the exam period and a couple of other persons. So let's call on those going for exam to make contributions. You know the way, Mike, I will call you, Sha, so that you can contribute. So who wants to be there?
Hello, good evening.
Yeah, Dr. Sorry, Conte, go ahead.
Yeah. Thank you very much, Dr. for that extensive presentation. First thing, I'm just wondering, with the left ventricular assisted device, you know, the implantation, is it done through an open thoracotomy or they can put it thoracoscopically? Because I'm just thinking about a patient who is in advanced heart failure. For instance, you're using an left ventricular assisted device as a bridge to transplant. That means the person will be having two thoracotomy within a very short period of time. That stress of surgery also might actually sort of worsen the outcome. So I just want to know the way they put the left ventricular assisted device. Is it open thoracotomy or they can do it thoracoscopically? Then the other thing concerning heart failure patients with a complete heart block. So if you get a patient with a complete heart failure patient that needs a pacemaker but does not have a left bundle branch block, the QRS duration is fine. Could bundle branch pacing be a viable substitute to CRT in such case? Thank you.
Okay, thank you very much. The context of the question. Okay, concerning the first question, it's actually done through a thoracotomy. Okay, but unlike that cardiac surgery where they open from up to down, okay, where they open from like the superior part of the sternum, okay, to the xiphosternum. This time around, they can only open up the lower part. I don't know how they do it. I've never seen it done before, but this is what I saw. That they make a cut just down the center of the chest, okay, and the surgeon will now separate the bone and now place the device. So it's a surgeon that actually does the assist device. It's not it's not an interventional procedure. Okay, that's what I think. So the issue of how the patient now transplantation and all that, I'm not sure how, because it means that the patient will not likely have to and I know that redo thoracotomies are usually more difficult. Okay, because the patient has a thoracotomy and it has been closed off. And if you want to do, I know the surgeons need there are some special equipment they need to do a redo. Okay, so how that will happen, sincerely, I'm not certain of that, but I'm sure that it's done to a thoracotomy. It may not be a complete thoracotomy like open heart surgery, but lower part of the sternum, okay, is open so they can have access to that apex where the device will now be, placed. Okay, then concerning your second question about his bundle pacing, yes, I agree with you. I didn't mention it, but I saw somewhere that yes, you can actually do this bundle pacing, okay, as if doing a CRT in a patient with like an AV block or a high grade AV block. Yes, you can actually do his bundle pacing. I'm not certain of how much benefit it will have over conventional CRT. Okay, but I know that conventional CRT is actually easier to perform. The expertise for conventional CRT is actually easier to do a CRT than to pace the his bundle. Okay, it's very specialized cardiac electrophysiology that will be able to do that his bundle pacing. Okay, maybe I don't know if I'll say this is what I have to say about your questions. Maybe I will appreciate more comments, understanding on this matter.
Yeah, thank you so much. I think we still have Prof. there was a time Prof took us on a lecture on some of these. Maybe when it's time for him to contribute, he will say more on that. Dr. Alagbe, please can you unmute and ask your question?
Okay, good morning. I say good morning, sorry, please. Good evening, chiefs. Good evening, my colleagues. Okay, so please, Dr. Charles, thank you for the presentation. It was a wonderful one. Please, I just want to ask, things like impeller, tandem heart, ECMO, and intra-aortic BP, intra-aortic, what? I've forgotten the name. IABP, please, where do they fall under what you've talked about? Thank you. Thank you, balloon
Okay.
pump.
Well, my understanding of impeller is an assist device, just type of LV, LVAD. Okay, impeller is like a type LV assist device. Okay, just the same I described, that there are different companies and all that. I'm not, but I know impeller is a mechanical circulatory support. Okay. Now, my understanding of ECMO is like well, my understanding of ECMO is like something that removes when you're cardiac surgery. Okay, you have to do bypass and all that. So you want to unload, you want to remove and ECMO is temporary. It's not like impeller that is like an assist device that's like we discussed today. Okay, so ECMO is maybe you want to how will I put it now? You want to remove just temporarily, okay, support the heart until you can do a more definitive thing. And ECMO is not like what the patient takes home. It must be done in the hospital. Okay, that's my understanding. But they are all mechanical circulatory support devices. Okay, that's my understanding. I'll still need for some of these things. I've not seen some of them, so I'll still need some more.
Thank you. Yeah, thank you for. We have a lot of assistants there. We have professionals, people who work directly with these devices, and we have those have experience. So maybe we'll get there. We'll make more contribution. Please, if you want to ask a question, you can raise your hand up or the electronic, and we'll mute you to speak. So I will wait until you want questions. Let me go to the chiefs in the house, Dr. Chuka. Please, any comment you have to make or contribution? Chief Chuka, sir.
Now, unfortunately, my network played pranks on me. It keeps coming off. However, I'll wait to take any question from any other person.
All right, okay, sir. So let's have Dr. AG. Dr. AG?
Yeah, good evening.
Okay, sir. So please, sir, any contribution before we take the first question from Dr. Florence?
Actually, I joined very late to the tail and when he was talking of the LVAD. I don't know, he mentioned some complications. He spoke about I think RV failure and then acquired von Willebrand disease. I don't know if you mentioned the reason why these patients are prone to acquired DX. I think that's usually an MCQ question, and these patients are actually prone to GI bleeding. So you have a patient who's been started an LVAD and then develops GI bleeding. It's usually due to impaired platelet aggregation, and then sometimes also due to AV malformations. I think there's also a third reason I really can't remember here. Then other complications, I don't know if you mentioned pump thrombosis, and then the driveline infection, and then sometimes also aortic insufficiency. And then the issue of, just like you said, somebody asked if I think impeller is what kind of device is that? So there are also forms of MCS, that's like mechanical circulatory support devices. And now you can classify them based on several parameters based on the duration of use, short term, intermediate, long term, based on the ventricle being supported, and based on sometimes on indication, based on indication of the device. There are many ways you can classify or divide these MCS devices. Now, the duration, like I said, can be intermediate, long term. So for the short term devices, that's a temporary MCS. You have IAP, you have Pella, you have Tandem, then you have ECMO. Those are basically, based on my understanding, are basically used for, in the short term, depending where you can have something more definitive. I think that's how I read it then. I really don't know if somebody has something else to add.
Thank you so much, Dr. G. And Dr. Aminatu, thank you. Let me welcome Dr. Florence. Please, you can unmute and ask your question. Meanwhile, Dr. Charles, please, I don't know if you have something to contribute on that, or we'll wait until we get further contribution from others. Sorry, Dr. Florence, can you hold on?
Okay, no, what Chifuji said is, Chifuji, thank you very much for your comments. They are comments and they are well noted.
All right, thank you. Okay, so Dr. Florence, you can ask your question.
Okay, good evening, Prof, senior colleagues and colleagues. Thank you so much, Dr. Charles. You did a great job. I just have one question to ask. You made mention of the INR being 1.5 to 2.5. So I want to know why that's low, because you said there are risks of thrombus formation. I know when people are being placed on anticoagulants, most times we aim at 3, and then even on maybe mechanical valves, maybe we aim at 2.5 to 3.5. And they said such patients on devices like this are at risk of thrombus formation. I don't know. Can you please explain to me why that's low? Like it's 1.5 to 2.5. That's what we should aim at for a patient with this device. I don't know. Please help me out. Thank you.
Thank you, Dr. Florence, for the question. Well, it was not stated. That's the source I saw it. It wasn't right, but I think that putting things together, they have high risk of bleeding. So because of that, you don't want to go high. Strokes, GI bleeding, and all that. The history of like what Chief was talking about, platelet dysfunction, acquired von Willebrand disease, all those things also put them at risk of bleeding. So I think they're at risk of bleeding, they're at risk of thrombosis. So the key in anticoagulation is actually to find the right balance, which can be difficult. So that's my thinking on why it's a little lower than what we know, the normal 2 to 3 that we know for most valve placement. That's what I think. Thank you.
Thank you so much.
Thank you, Dr. Charles. So in the absence of any further questions and contribution, let me call on Dr. Kweki. Dr. Kweki, sir. Okay, Dr. Ajayi, you want to say something?
Yes.
All right,
thank you very much, consult teachers. Yeah, thank you, Chief Okopisa. My question is this. Thank you so much for the presentation. It was really expansive. I recollect, Dr. Okopisa will remember this. There was a question in the orals. I think it was actually the same exam that we did, because I remember it during a discussion. One was saying they painted a scenario of a patient who had heart failure with reduced ejection fraction less than 35. Patient had sinus rhythm, but the QRS complex was said to be 0.12, that's 120 milliseconds. And the next questions that followed was something along, what would you do? So, because if you look at it on one hand, it looked as though they were trying to push one into device therapy. But at the same time, when you look at, in the context of this presentation, that patient didn't have a wide enough QRS complex to merit a CRT. To merit a CRT. So I was thinking that, okay, the argument might go more in line for an ICD than a CRC. I just wanted to know what your thoughts would be, sir. Thank you.
Okay, thank you, Dr. Jai, for the question. I agree with you. Because of the QRS complex less than, being at 120, that patient will not qualify for a CRT. But if it depends on the other parameters now to now know whether the patient qualifies for an ICG. You want to know what is the NYHA class of the person, because ICDs, remember, they must be NYHA class 2 and 3. The EF depends on these other things. The EF must be less than or equal to 35% despite more than 3 months on optimal medical therapy. Then they must have an expected survival of more than 1 year. So that just simply tells us that you don't want to give an ICD to a bad patient or to a patient that will die in less than 1 year from any other, maybe from renal failure, from cancer, whatever. So it depends on the other things in the question. But that 120 alone disqualifies the person from having a CRT. Because they have been shown not to benefit. Patients with low QRS duration have been shown not to benefit from CRT. So that disqualifies the patient from having a CRT. So other things that the person may now benefit from, he may benefit from an assist device, depending on the ejection fraction and other things that were mentioned in the question, which the details we don't have here. So I think those are my comments on what you said. Thank you.
Thank you, sir.
Thank you.
Hello, just to comment on that question.
Dr. Kweki, you can just
just
continue.
so I know I'm going to talk later, but so that we don't miss some thoughts.
No, actually, you can continue because you're next to talk. So
okay, so thank you, Dr. Ajayi. If I get your question very well, you're trying to say that the patient met every other criteria for ICD or BCROT, but the QRS complex duration, is it not?
Yes, yes, and
that QRS complex duration was between what and what?
120 milliseconds was what was written.
So 129 thereafter. Is it your exam question or what?
Chief, it was one of those recall I saw. What they said was 120. They didn't say 129. They didn't give it as a range. Maybe it was also a perfect recall. I don't know. There might have been variance from actually what they asked. But if I recollect, what I saw on that paper was like the QRS complex was 120. What would be your next line of action? What are the indications? What are the contraindications? Blah, blah.
Okay. So I remember that was my exam. I remember that station. Every other thing just fits, except the QRS complex duration. Because we expect that in a patient that should have CRT, QRS complex should be, as per guideline, more than 130. But I remember that question. That was the only thing missing. And the moment you just mentioned CRT, who was there? Was it Dr. Dalbauchi that was there, or someone else? Can't remember. Maybe Prof will remember. He will now point your attention to that QRS duration that is as the usual QRS duration that you expect. So when I came back, I looked at that question. I realized that it's a class 2B also indication for CRT 120 to 129 thereabouts. Class 2 more than 130 is a class 1 indication, but once the QRS complex duration is between 120 to 129, we can confirm as per guideline, it's there. And it's a class 2A also indication for insertion for CRT. So that was the basis of that question. I think I'm one of the people that report that question at that time. So if you could pull out those guidelines, I saw initially you were trying to talk about those guidelines. If you could pull it up, I think it's around that. So it's not a class 1 indication, but anyway, as usual in an exam, you must say something. I think a lot of people tilted towards talking about angiogram thereabouts. So that's what I can remember about that question. So I thought I should just share that line with you. So so fantastic presentation generally, advanced heart failure and approach to management. I think you done.
Oh, sorry, please, Dr. Quick. Sorry, I just want to get your clarification. If they were to answer such question in the exam, would you advise them to go for class 2?
Okay. So check. Okay, I think it's not. This one says it's not recommended. 120 to who do not have indication for pacing of height. Then shouting becomes not for. First, the question you asked, Dr. Copy, that station. I'm sure I didn't fail it because I had to move the examiner to talking about coronary angiography because he kept talking me, no. So the moment I moved into coronary angiography, it was accepted what I was saying. And then we kept talking about angiogram, complication, indications, issues, So probably sometimes they realized that a lot of candidates had difficulty and issues with it. So they had to allow a candidate to go in a direction.
Okay.
So CRT can be considered for symptomatic patient with heart failure, sinus rhythm, duration of 130 to 149, and non-ABB. CRT is not recommended in a patient with less than 30% who do not have indication for pacing. Any other one again? Yeah, so I can see this. So in the class 1 indication, you recommend for symptomatic patient with more than 150. Okay, so this is what I'm trying to say. Then class rather than GPC. So the usual criteria is more than 150. Yeah, correct. The next one, can you just, I need to see the yellow one, the yellow point, not the green. Yeah. So patient would there be who have received a conventional okay, I think there was one patient with duration of 130. So I think this is what I was talking about, 2A indication. So CRTD should be considered for symptomatic patient with heart failure and sinus rhythm with various complications between 130 and 149. So so no more than 150. So this is 2A, yeah, this is the 2A I was talking about. So that's what I thought of after the exam, that I'm sure they gave a range, not just 120. I think they gave a range that was less than the usual 150. I beg your pardon for my earlier statement. It's 150. So they gave a range, and it was just less than the usual criteria that a patient will have to require ICD. So still have the LBB, still have the other criteria, but the cardiac complex duration was just the problem, was less than 150. I remember very well because he gave me headache in the exam. I had said this patient will need CRT, but the examiner was just telling me here and there, but why is this cardiac complex duration is no more than 150? As they asked me, what's the usual cardiac complex duration? I said more than 150. But why is this one less than 150? So that's why we started arguing. So then I didn't really pay attention that this is a class 2A indication. So that would have been a point of argument to be able to convince the examiner. But anyway, in the course of the discussion, we'll move into coronary angiography, and that's how we'll talk and end the exam. So if it comes like this, I would rather suggest that in the exam, you could talk about the guideline, class 2A indication for CROT. Maybe that's what they were looking for in that station. But obviously, from the other statement, once it's less than 130 and there are no clear-cut indication for pacing, especially due to high AV degree, AV block. So there's no indication for that. Okay, Dr. Kopi. Okobi? Dr. Kopi, are you still there? Hello, is it me or every other person can hear me?
We can hear you, sir.
Okay, I think it's Dr. Kopi. Okay, so that is my thoughts on that question that you asked. So just to be able to maneuver whether this is class 1 or class 2A indication for CRT. So my comment generally, that's the presentation. I think it's to continually read the stuff and put them together. I will try not to ask us individually questions because I felt we should read it to have exam, can memorize as much as possible of what you have. I think what we need to also pay attention to is the indication that define advanced heart failure or end-stage heart disease. I love the fact that he talked extensively on the device therapy, which is something the examiners are interested in. These indications are very important, very essential. So CRT, CRT-D, CRT-P are things that you want to look at. The concept of bundle branch pacing, it's something that, or his bundle pacing, something that they've talked about recently. You know, one of the problems with CRT-D is because sometimes those guys, prof and code that does a lot of intervention in cath lab, I give hand to them. I never knew that would be crazy, but sometimes it's a whole lot of work. I remember when we were in Abuja with Dr. Edafe for one of those symposiums. They spent hours, more than 6 hours, trying to maneuver to be able to put the lead to the left ventricle through the coronary sinus. Sometimes you have a lot of difficulty to be able to, engage the coronary sinus properly. So that's one of the problems with CRT. Of course, the more you do it, the more you get used to the procedure anyway. But so because of that, there is now a concept of his bundle pacing where you pace at the level of the his just below the AV node. The idea is that if you could pace that, you need to see whether you could achieve similar synchronicity between the right and the left ventricle. But the data have been conflicting. We really not achieve any fantastic positive outcome with the data. In fact, we had a patient, was it 2 weeks ago, that they had wanted to insert CRT, but they had problem. They had problem trying to assess the coronary sinus because of the anatomical variation. The elderly patient, about 80 years of age. So we had to resort eventually to his bundle pacing. But eventually did not improve the cardiac function, did not improve the exercise tolerance of the patient. We still have to start optimizing medical therapy to help the patient. So the data are still limited, are still conflicting. Some quarters have said that it helped with better outcome. So data are not really, so it's a new thing that they're still trying to get across. That's why most things are not clear cut yet on the guideline because they're also trying to get it across. So we need to keep that in mind. Let's just remember that that's a concept that's currently being looked into and see how it can be used in the future. If we can achieve the same result as the LV pacing, LV pacing the left ventricle, that will be a fantastic modality in the future. Just the same, for whatever reason we don't know, for patients that have LBB, and you tend to give them CLT, they don't do so well compared to patients who have LBB. Patients with LBB and you do the biventricular pacing, they tend to have a better outcome. So not so sure why, in terms of the data now, are not in support. Clinic, in terms of physiology, you will expect that you should have a good outcome, but the data are not in support in patients with LBB block that you have to do biventricular pacing. So let's just keep that in mind. The other thing I'll talk about again is the concept of heart transplant. Heart transplant is possible, but these are really done in centers that have the required skills, because beyond just having the cardiologists, you need every other team to make it work. So you have the pulmonologists, interventional pulmonologists, that quite supportive in patients that have the end-stage renal disease where you have to need heart transplant. Remember that sometimes beyond just heart transplant, patients also require heart-lung transplant. I'm coming, I'm in a meeting.
I'm only ready for bed.
Okay, sorry, I'm in a meeting. I'll talk to you later, okay? So it's really, I think it's something that they commonly do, but patient World Cup is essential, like you have all talked about. Issues of LVAD, talking about the bridge to destination, bridge to therapy, bridge to recovery, and all the rest. I think there are terms that we need to also pay attention to. I'm trying not to ask what those things mean, because I expect that we'll look into it. But if you have any question, you could ask so that we'll discuss it. And of course, the presenter is also here to explain some of these concepts. I believe that exam is few days from now, and we have to maximize the little time we have to be able to catch up. So these are the few things I have now. Along the way, there are other things I would comment and also add one or two things. Thank you so much.
Wow, thank you so much, Dr. Kweti, for always having the resources that we need to understand this concept better. I think in rounding up, we'll call on, if there are no questions again, then we call on Prof. Immediately after Prof finishes, we should have the next presenter. Dr. Aminatu, you can start sharing your slide by Prof. Wrap up. Or wait a minute, should probably need to call up some of the slides. Hello, Prof. Sir. Thank you, sir.
Chief Mokopi, thank you so much. I want to appreciate the presenter. I also want to appreciate Dr. Kweki, everyone that has spoken. Yeah, so just to answer Dr. Conti's question regarding the implantation of these devices. So it's important he understands that, as one of our chiefs said, there are two types of ventricular assist devices. So you have the short term and the long term. So the ones you use for short duration, most of them you can implant percutaneously. That means you just do a percutaneous puncture, either the femoral arteries or the axillary subclavian arteries, even through carotids. Okay. So examples are the impellers, right? The ones that are long term, most of those times you will need the surgeons to come in to be able to do some thoracotomy to implant them, because you will need to kind of perforate the ventricle to put them and connect and perforate the aorta to put them. So they are like a bypass tubes. Okay, so that one will need the surgeons to come in to do that. So it depends on the type of assist ventricular assist device you are discussing. That will determine the mode of procedure that will be useful to implant it. Okay, Chief Conti, hope that answers your question.
Yes, Prof. Thank you so much.
So the second question, I think you asked another question regarding, there were two questions you asked.
Yes, about the option of using his bundle pacing.
Okay,
yeah.
Okay, so Dr. Kweki has tried to help you that. See, one important thing you have to understand the concept is when you talk of ease bundle pacing, that means you are trying to pace above at the ease level. But the question you should ask yourself is this: a patient presents with LBB is still lower than the ease, right? So if you are pacing at the ease level, as that sorted the bundle, left bundle branch block. Chief Conti. So that is why ease pacing, when it started around 2014, 2015. The data generated did not show any, in fact, it was a flaw because you did not overcome the left bundle branch block. You were pacing above the block, not below the block. So that was why CRT was more useful. Now, the concept that is now gaining more grounds now is the left bundle branch pacing. Left bundle branch pacing, ability to pace beyond the block level, is gaining more concepts and is only considered for patients where CRT is difficult. Probably they couldn't access the coronary sinus or has abnormal anatomy that you just could not access the coronary sinus. Those kind of patients may benefit from left bundle branch pacing. That is different from ease pacing. Hope you get the two concepts, sir.
Yes, bro.
Yeah, so now the only challenge now with left bundle branch pacing is that what if you pace or you fix your leads and it's still above the block, then it's still a problem. If you're going to do left bundle pacing, you must make sure your lead gets beyond the block, because anything you pace above the block is a block. Nothing will happen. So that is still the problem that is affecting left bundle pacing, because it can be as low to the level of the Purkinje. So you can see it's a problem. You get. So but the bottom line is that for those that CRT is not possible, then left bundle branch pacing is their best option. You get that? Not ease pacing.
Yes, bro.
Okay, hope you get the concept. So we've been to answer your two questions. Yeah, I think there was a question about ECMO, impeller, IABP, and I think one of our colleagues has answered that ECMO impeller, they have for temporary, short-term assist device. Okay. Now, but technically, ECMO itself, I need you to understand the way it works. ECMO, if you have seen a bypass machine, for those patients that will do open heart surgery and they need going to do a bypass for them, the same way that machine looks like is the same way an ECMO machine looks like. Okay, it's like a bypass machine. So you connect one tube, or let's say like your dialysis machine. Okay, so you connect one tube to the artery and another tube to the vein, depending on the method you are following. If you're doing veno-venous, it will be one tube to the vein, another tube to the next vein. That means two femoral veins now. If you are doing veno-arterial, It will be one to the vein, one to the artery. Okay. Now, one important thing you should understand is that one tube that is connected to vein, right, will suck blood, right, from the patient into the machine. Now, the machine is equipped with oxygen. So it fills, it oxygenates the blood. Then the second tube carries the blood from the machine to the patient. So the patient is able to get oxygenated blood. But one important thing is that if you have that kind of a machine, you know, patient cannot leave the hospital. So it has to be a patient in the ICU. So it's just a temporary stopgap till the patient can get a definitive treatment. If the patient is in cardiogenic shock, is a stopgap to get the patient out of cardiogenic shock. If the patient is in shock and there is going to be a candidate for transplant, it's like a bridge to transplant. So those are informations we need to know. And as Dr. Kweki said, all those terms, bridge to decision, bridge to transplant, destination therapy, you should know the meaning of each of those terms. It comes out in MCQ. Almost. I don't know, Chief Okopi, did you see it in MCQ? Oh, we saw it.
Yeah, I saw one in our last question. There was one classical scenario. It will just be very long, and it's just be bridge to destination. Exactly. Long statement. It's a bonus track.
Okay, thank you very much. I think we've answered all the questions. Except there are more questions you can ask. Thank you.
Thank you so much. Please, do we have any more questions to ask?
Okay, thank you so much. For Ajayi, the question you asked about a patient having a QRS duration of 120 milliseconds. Actually, Chief Kweki, it was actually 120 milliseconds. So I remember that question very, very well. You understand? And I remember that the no-go area was to mention CRT. It was never it was not a go, it was a no-go area. So the answer actually was a ICD. Okay. But one important thing is that they were not just looking for you to mention ICD alone. They were also looking at the fact that you are supposed to investigate the patient if he has a treatable underlying condition. So the cause of the cardiomyopathy was ischemic. We will have supposed to have done a angio PCI and results and treat that to see if the patient's ejection fraction would improve. So when you mention that and they say, okay, you've done PCI, you've done angio, and I remember they also asked about the complications of angio and all that because I mentioned on that. So then also the it was Prof from Kano that was in that station, Professor Sani, I guess it's from Kano. So the next question was, okay, now that you have done PCI and you did not see any improvements, is there any other advice or therapy you can give the patient? That's where ICD comes in. Okay, so they start asking also what will be the time between vascularization and ICD and things like that. So the bottom line is investigate your possible underlying etiology, manage that underlying etiology, and if advanced therapy is needed, ICD, not a CRT. Okay, thank you very much once again. Have a blessed time.
Thank you.
Thank you so much, Prof. Thank you, Dr. Ajayi, for calling up that question. Any other question from anyone before we take the next presentation? All right, Dr. Charles, you can unshare your slide. Let Dr. Aminatu put up a slide. We have a couple of presentations to take before the guys going for exam next upper week. So tomorrow we'll take fetal circulation. Next tomorrow we'll take septation in biology. And then Dr. Namono will be giving us heart transplants. Then subsequently next week we'll take some high-yielding areas. So Dr. Aminatu is available to take us on hypertrophic cardiomyopathy. Dr. Aminatu, are you there?
Yes,
Aminatu Jafar.
Yes, can you hear me?
Yes, we can hear you.
Okay, let me share my screen.
Okay. Thank you so much, Prof. Again, for the excellent contribution. Thank you, Dr. Kweki, for the contribution. Thank you, EG. Thank you, everyone. Thank you, Chuka. Thank you, Florence. Thank you, Dr. Okori, for the time you invested in bringing out that brilliant presentation. Thank you, Dr. Christy Alagria. Thank you, Dr. Conte. So Dr. Aminat will be taking us on hypertrophic cardiomyopathy. I think she has 45 minutes, then we'll interact afterward. Thank you.
Thank you, Dr. Kobi. Can you see my screen?
Yes, we can
Okay.
see your screen.
Okay. Good evening, everyone. My name is Amina Jafar. I will be taking hypertrophic cardiomyopathy tonight. I will be using this outline from introduction to definition. We'll discuss genetics, clinical presentation, treatment, and prognosis. Okay. So as a form of introduction, hypertrophic cardiomyopathy was first described in 1964. It's a relatively common primary cardiac disease and the most common genetic cardiovascular disease. HCM is characterized by left ventricular hypertrophy of various morphologies with a wide array of clinical manifestations and dynamic abnormalities. We have two types. There is the obstructive HCM, which it has a dynamic left ventricular outflow tract obstruction. Then we have the non-obstructive HCM. The prevalence globally is about 1 in 500 in the population. It affects all age groups from infancy to old age, although majority of patients are identified in adolescent age or young adulthood. Peak incidence is within the third decade of life, and the male to female ratio is between 3.7 is 3.7 to 1, males being more common than females. In a retrospective study that was done in Lut, showed that there is a prevalence of about 2%. That was published in 2017. Annual mortality is estimated to be about 1 to 2%, and it is the #1 cause of sudden death in adults. Hypertrophic cardiomyopathy is generally considered as a disease of, as a genetic heart condition. And although only 30% of patients have evidence of genetic etiology, with the pathogenic disease-causing mutations being seen. Mostly it is autosomal dominant inherited mutation, which is highly variable. It has a it's highly variable expressivity and it has related penetrance, age-related penetrance, sorry. Variants in gene encoding thick or thin myofilament proteins of the cardiac sarcomere are frequently seen as the cause of HCM. There are over 1,500 mutations among these genes. The most common mutations seen is missense or frame shift. So missense is when there is a complete replacement of an amino acid for another one in the sequence, while frame shift is if there is deletion or insertion, thereby making the sequence longer or shorter. So in HCM, missense is usually seen, and frame shift is less seen. So the MYBPC3 and MYH7 gene mutations are the most commonly seen. In an analysis done of 33 genes frequently included in HCM testing panels, they found out that out of the 33 genes that were frequently seen, 8 genes were identified as definitely causative. 3 genes showed only moderate evidence of causation, and 22 genes, that is 67% of the 33 genes, showed frequently minimal or no evidence of association with HCM. So even though we know that about 30% of patients with HCM are known to have the gene mutation, just about 30%. Out of this 30%, a large number of them, the genes that were identified were shown not to have any evidence of association with HCM. So the genes that with definitive evidence as being causative are listed here. So for the sake of MCQs, we have from cardiac troponin T down to tropomyosin 1. So these are about 8 genes that are commonly seen as definitive evidence of being causative. The pathophysiology of HCM involves 4 interrelated processes. We have the left ventricular outflow tract obstruction, mitral regurgitation, diastolic dysfunction, and myocardial ischemia. So these processes occur about the same time. They're interrelated. So here is an image showing the integrated pathophysiology. So at the center is the hypertrophic process that is the beginning of the condition. So from the hypertrophic process, there could be obstruction. That is, if it is the obstructive type. Obstruction will lead to impaired relaxation. Obstruction would also lead to myocardial ischemia. Hypertrophy also leads to myocardial ischemia. So impaired relaxation too can lead to myocardial ischemia, and myocardial ischemia can also lead to impaired relaxation. So, and then still the hypertrophic process can also lead to diastolic dysfunction. Then when we come down, the hypertrophic process also leads to cardiac arrest, syncope, that is for patients that develop malignant arrhythmias. All these processes occur about the same time. They are integrated. So one cannot say exactly if a patient is through one pathway or two pathways. It can be more than one or two of the pathways. So specifically for obstructive HCM, the mechanism of obstruction are two. There is the systolic anterior motion of the mitral valve, which is caused either by the Venturi effect. That means that when there is accelerated blood flow through the ventricular outflow tract, it creates negative pressure, which pulls the mitral valve towards the septum. I will show an image later on. So this will cause an increased outflow tract obstruction. That is what we call the Venturi effect. Then there is abnormal mitral valve location. So these two are causes of one of the mechanism of obstruction in HCM. There's also the muscular obstruction, whereby there is encroachment of the left ventricular outflow tract by the hypertrophic septum. The clinical manifestations. Many patients with HCM have no or only minor symptoms. Individuals are often diagnosed as a result of family screening, detection of murmur during routine examination, or identification of an abnormal ECG. Symptoms of left ventricular outflow tract gradients are most common presentations. Patients will have mild to moderate limitation. They experience usually slow progression of symptoms with advancing age in association with modest deterioration in LV function. So majority of these patients are asymptomatic. This is an image showing so from left to right, we start with this is the normal heart. Then the next image in the middle is the non-obstructive type of HCM. You can see here the hypertrophy is evident from the septum and even the anterior free wall. Then, but the LVOT is not obstructed. Then the third image is showing us where there is the obstructive type. And if you can see a pinched out image here, is showing the, sorry, okay. The pinched out image is showing this is the left ventricular outflow tract. And then this is the hypertrophied interventricular septum. And then this is the mitral valve. So with contraction, this is showing the Venturi effect. The contraction causes the mitral valve to move towards the septum. Moving towards the septum will cause more obstruction in this place, which is the outflow tract. So that's what causes the obstructive type of HCM. HCM has about 5 clinical pathways. It can be stable benign clinical profile where the patient does not require any major treatment or intervention. Then there could be left ventricular outflow obstruction with significant heart failure symptoms, just like the usual heart failure patients. Then they could present with increased risk of sudden death due to arrhythmia. Like we mentioned earlier, is the number 1 cause of sudden cardiac death. Atrial fibrillation and risk of embolic stroke is also another pathway to presentation. And then there could be the non-obstructive end-stage phase with advanced heart failure. So even those that have the non-obstructive HCM may end up with HFpEF and develop advanced heart failure. It should be noted that only 10% of HCM patients experience more than one of these adverse pathways. Usually, the majority of them have just one of the pathway, but if you find a patient with more than one of these pathway, then it's the minority of patients. So this is just a graph showing the frequency of HCM pathways in about 1,000 patient cohort that were examined. So the blue showing about 46% no adverse pathway. So like we said, it is majorly asymptomatic. Then the red is showing the, and out of this 43% that have the progressive heart failure, majority of them have the obstructive type of HCM. Then about 17% will present with AF and complications of AF, and then 6% will have sudden cardiac event. So what are the clinical findings? We find a biphasic pulse in the patient, systolic ejection murmur, that is the crescendo murmur, which is similar to the murmur of aortic stenosis. And this murmur increases with any maneuver that increases peripheral vascular resistance, such as, decreases, such as increases with Valsalva maneuver, standing inotropic drugs, and the murmur also decreases with hand grip, squatting, or passive leg elevation. There could be a possible polysystolic murmur. There is sustained beat, double or true apical impulse. There could be an S4, and then there is a paradoxical beat of S2. So this is a chart showing the clinical evaluation. So if there is a suspected case of HCM, a history is taken, physical examination done to find some of the findings we discussed earlier, and then a detailed family history is taken, especially history of sudden cardiac death. Then we move to testing. Testing is usually the non-invasive testing that is done. ECG, echo is this point phenotype of the HCM, is it the obstructive or the non-obstructive type? And then it's if it is the obstructive type, if there is obstruction, then we check. If there is no obstruction, we do a stress echo to see if there is provocable obstruction. If there is none, then it is the non-obstructive type. Then for genetic testing, remember that only 30% of these patients are found to have the gene with mutation. So family members that are being tested for that are having the genetic testing, usually patients that have the phenotype after this non-invasive test. So they can end up being genotype positive and phenotype positive. So this is the green pathway here. And then, or they can be genotype positive and phenotype negative. So if they are genotype positive and phenotype negative, it means they have the genes, they've tested positive for the gene, but they do not have the physical findings. And even the non-invasive is negative. So these patients, we do surveillance for left ventricular hypertrophy development in them. So echocardiography is one of the non-invasive tests that is done, and it is the investigation of choice to confirm diagnosis. It distinguishes the presence of obstruction at rest or with provocation, a gradient of more than 30 millimeters mercury. In adults, a maximum LV thickness of more than 15 millimeters at any site in the chamber is consistent with diagnosis of HCM. But if this individual or this patient has a positive family history, or he or she carries the pathogenic gene, then a diagnostic. Average maximum LV thickness reported in adults has historically been around 21 to 22 millimeters. Thickness is usually asymmetrical, the septum being the most frequently affected, but it can affect any other segment, and the apex can also be affected, but the most common is the septum. Echo has the capability to characterize the systolic anterior motion of the anterior mitral valve leaflet, and it reliably quantifies subaortic gradient using the continuous wave Doppler. It also characterizes the magnitude of mitral regurgitation, provides an assessment of the morphology of the mitral, which will demonstrate physiologic exercise-induced obstruction better, and is preferred to pharmacologic provocation that is done with some agents. Then the gradient of more than 30 millimeters of mercury has prognostic value, including prediction of New York heart class progression. So for those that progress to heart failure. So during echo, finding a gradient of more than 30 has a prognostic value. So this is a video showing the anterior systolic motion, systolic anterior motion. Let me go back a bit and start. So there are some labelings where you see this is the plaques view showing the mitral valve, and you can see the left ventricular hypertrophy, both sides, the posterior wall and the interventricular septum. This is you can see the systolic anterior motion of the mitral valve. The mitral valve, when the heart contracts, the mitral valve touches the septum, causing obstruction at the outflow tract. This is the four-chamber view, also showing the hypertrophy in the LV. And then you look carefully and you can see the systolic anterior motion of the mitral valve, causing obstruction at the LVOT. Okay, and then this is the gradient that is measured, very high gradient due to obstruction. So these are just echo views too. So A is a plaques view showing the hypertrophied interventricular septum and the posterior wall. The B is the short axis view at the level of the mitral valve, and C at the level of the apex, at the apical level. Here, image D is showing the four-chamber view. So all these images are just showing the hypertrophied left ventricle. ECG. Resting ECG has no proven role in sudden death risk stratification, but can be done at baseline and annually for patients. We see left ventricular hypertrophy with string pattern. Deep Q waves in inferior leads and lateral leads can be seen. Then giant inverted waves in prepodial leads can also be seen. However, ambulatory ECG has a more risk stratification benefit. It is done at baseline and subsequently every 1 to 3 years. It is done to detect patients that are having arrhythmias. The common arrhythmias that are usually seen are atrial fibrillation, atrial flutter, or ventricular tachycardia. Cardiac MRI. Currently, it is an integral part of HCM assessment. It is synergistic with echo, but it has its own advantages for diagnosis and risk stratification, even though it's an addition to echo. So advantages include a situation where the echo is suboptimal in diagnostic quality. Then it provides enhanced precision of ventricular septal thickness. It identifies the hypertrophy in areas of LV that are usually blinded in echocardiographies, such as the apex and anterolateral free wall. There is proper quantification of the LV mass and function. You can also do there is myocardial tissue characterization by LGE, and having the burden of LGE shows more burden of fibrosis. Preoperative planning can be done before invasive septal reduction. That is surgical approach to treatment, which we'll discuss later. So MRI is done so that one can have a better outline of the left ventricular hypertrophy. Then it enhances sudden risk stratification, just like in ambulatory ECG. So these are MRI images from image A to F, showing different areas of the hypertrophy. So in A, there's massive septal hypertrophy. And massive septal hypertrophy is an independent risk factor for sudden cardiac death. So we can see here, this is the ventricular septum, and this black area is quite massive. So it's an independent predictor of sudden death. Then in the second one, you can see this is the area of hypertrophy at the anterolateral free wall. Then D, you can see in there's apical hypertrophy here, which they call the spade-like contour. So these are the MRI features that are usually seen. So with MRI, one can clearly delineate where the extent of hypertrophy. And F, this is more significant. F. E shows aneurysm. I don't know if I'm finding it hard to use the, okay. So E shows LV apical aneurysm, and this is the aneurysm here. So for F, it shows the LGE. A patient already has heart failure with preserved ejection fraction, and this is the LGE, which shows the burden of fibrosis in the LV. So management of obstructive HCM. We'll manage both the obstructive and the non-obstructive. Medical therapy, the management is can involve medical and surgical therapy. For medical therapy, it only provides relief of symptoms. It does not affect long-term outcome. These drugs reduce the outflow gradient. They have a negative chronotropic effect, which helps maximize the preload by increasing the diastolic filling time. So like we know, the major problem or that causes the major reason why these patients have symptoms is the increase in gradient, the difference in the pressure. So if we increase the diastolic filling time, we'll maximize the preload, and then the gradient will not be as high. So first line drugs are beta blockers and non-dihydropyridine calcium channel blockers. These are usually drugs that are used. Therapeutic efficacy is guided by symptomatic response, not the change in gradient. So once the patient starts feeling much better, symptoms are resolving, that means there is therapeutic efficacy, regardless of the change in gradient when we do an echocardiography. So the new drug, mavacamten, is one of the medical therapy that is being used. This drug is well tolerated. It was approved by the FDA in April 2022. Mavacamten is a selective allosteric reversible small molecular cardiac myosin inhibitor. It represents the first disease-specific treatment for obstructive HCM, targeting the core pathophysiological mechanism of the disease. It causes reduced left ventricular outflow tract gradient, improves exercise capacity and symptoms. Mavacamten is associated with it has been found to be associated with improvement in other clinically relevant parameters, such as patient-reported outcomes and circulating biomarkers as well. So this is an image showing myosin, the mechanism of action of mavacamten. So it's quite just direct and simple. This is the normal sarcomere of the cardiac myocyte. You can see this is the thin actin filament. This is the thick myosin filament, and this is the actin-myosin cross bridge. So this is a normal sarcomere. It has normal contractility and effective relaxation. So for patients that have HUCOM, this is how their sarcomere looks like. They have the actin and the myosin, but they have actin-myosin cross bridges much more than the usual. So there is hypercontractility, impaired relaxation, altered myocardial energetics. So with patients that are on mavacamten, you can see the difference if you compare it with the previous image. The actin-myosin cross bridges are less. So it improves relaxation. Basically, this is what the drug does. Surgical therapy directly addresses the cause of the obstruction. Septal myomectomy has evolved since its introduction about 60 years ago. And the beauty of surgical therapy is the fact that other surgical procedures can be done during the surgical therapy, such as manipulation of the mitral valve. Maybe a mitral valve repair has to be done, as these patients can have coexistent mitral valve regurgitation. And then maybe these patients have atrial fibrillation, so AF ablation can also be done concomitantly. So that's the benefit of surgical therapy. Myomectomy is durable and can reverse heart failure in 90 to 95% of patients. There has been success rate in experienced centers. Another option is alcohol septal ablation. It's an alternative procedure, but is reserved for patients that are frail and they have significant comorbidities and they cannot go through the stress of surgery. Although ablation therapy has less surgical risk, like I said, but there is a risk of heart block that may require permanent pacemaker, which should be borne in mind while choosing for the patient. This is just a chart showing obstruction, the management of obstructive HCM. So majority of patients, like we know, of HCM are asymptomatic. So for those with obstructive HCM that are asymptomatic, no drugs are usually needed. Then for those that are symptomatic, presenting with exertional dyspnea, fatigue, and so on, sometimes they present with syncope, then we introduce drugs, and first line is beta blockers or non-dihydropyridine calcium channel blockers. And then, like we mentioned earlier, mavacamten is now a choice. Then if these patients do not do well and they progress to heart failure, if these patients are still having progressive symptoms, then we consider surgical options. If they are aged patients with major comorbidities, then we go for alcohol septal ablation. But if these patients are fit, usually young, and they do not have much comorbidities, then surgical myomectomy is preferred. The management of non-obstructive HCM, patients usually present with symptoms of subendocardial ischemia. So they present with angina and HFpEF. As we know, the HCM gives us a picture of diastolic dysfunction, diastolic heart failure. So they present with dyspnea and they are diagnosed with HFpEF. First-line agents are also beta blockers and non-dihydropyridine calcium channel blockers. For patients that are congested, we can use diuretics to decongest them. So for patients that have ejection fraction less than 50, we manage them with guideline-directed medical therapy as HFrEF. This is an important point for HCM. For HCM, HFrEF is considered when the EF is less than 50, not less than 40. Patients in HFrEF who progress to advanced heart failure may require device therapy or cardiac transplant. This is also a chart showing the outcome, the treatment of non-obstructive. So if asymptomatic, you do not give any medications. If they present with symptoms, they are patients with preserved ejection fraction, that's the EF is greater than 50, we can choose beta blockers or verapamil. And if they progress with symptoms of heart failure, we can introduce diuretics to decongest them. And if all that fail, we introduce ICD and finally heart transplant. But if these patients have reduced ejection fraction less than 50, then we go to treatment of heart failure with reduced ejection fraction. And then if it fails, we move to device therapy or heart transplantation. Another cornerstone to treatment of HCM is atrial fibrillation. So they may present AF, and estimated about almost 50% of HCM patients will have atrial fibrillation, with prevalence increasing with age. AF substantially reduces the preload through loss of atrial contribution to the LV field. Also, there's that the diastolic period is cut short as heart rate increases. So all these contribute. So for patients that have AF and they have POCOM, you will need both rate and rhythm control, because these are targets for therapy. You will need to reduce the rate, because as the rate increases, the diastolic filling time is less, and these are patients that are already having myocardial ischemia because of the left ventricular hypertrophy. We use beta blockers, verapamil, diazem, any of these drugs to control the rate, and then amiodarone and other antiarrhythmics listed here for rhythm control. Catheter ablation is an option if medical therapy fails. So, and patients that are going for catheter ablation and are going for surgical myomectomy, this can be done concurrently. The risk of thromboembolism with HCM and AF is higher than in patients without other structural heart diseases. According to 2023 ESC guideline for cardiomyopathies, oral anticoagulation is recommended in all HCM patients that have AF without need for any risk scoring. We just commence them on oral anticoagulation. However, for patients that have subclinical AF and patients that have AF less than 24 hours, these patients, there is no data to justify anticoagulation. So decision should be individualized. Another cornerstone to treatment is prevention of sudden cardiac death. Risk stratification is an integral part of clinical management of HCM. Most contemporary series of adult patients with HCM report annual incidence of cardiovascular death of 1 to 2%, with sudden cardiac death, heart failure, and thromboembolism being the main causes of death. Most commonly recorded fatal arrhythmia is ventricular fibrillation, followed by asystole, AV block, and pulseless electrical activity. So there are factors, risk factors that are associated with increased risk of sudden cardiac death. Age, increased risk is in younger patients. Non-sustained ventricular tachycardia, this is an independent predictor of sudden cardiac death, as well as massive interventricular septum, like we mentioned earlier. Maximum LV wall thickness of more than 30 millimeters. Family history of sudden cardiac death at young age. Patients that have unexplained syncope. Patients that have left atrial diameter is enlarged. The left atrium is enlarged, sorry. And then the left ventricular outflow, patients that have left ventricular outflow tract obstruction, and those that have systolic dysfunction with EF of less than 50%. Those with extensive features of fibrosis, that is LGE on cardiac MRI. So these are all risk factors for sudden cardiac death. Age and non-sustained ventricular tachycardia and extensive LGE on CMI are considered as risk modifiers as well. So this is the 2020 ACC recommendation for selection of ICD device for HCM patients. I find this more straightforward than the ESC guideline, which I will show later on. So it says that when a patient has prior event, be ventricular fibrillation, sustained ventricular tachycardia, or survived a sudden cardiac arrest, if this patient has any of these events, then straight ahead patient is recommended for ICD. It's a class 1 recommendation. However, if the patient does not have any and has at least one of the following: family history of sudden cardiac death, massive left ventricular hypertrophy, unexplained syncope, apical aneurysm, EF less than 50. So the previous risk factors that we mentioned earlier. If the patient has at least one of the following, then ICD is reasonable. So it's a class 2 recommendation. However, if the patient does not have any of this, but has non-sustained VTAC, yes. If the patient is a child, then we consider ICD. But if the patient is an adult, sorry, ICD is reasonable. That's class 2 recommendation. If the patient is an adult, then we may consider ICD. Now, if this patient did not have any non-sustained VTAC, then, but the patient has extensive LGE on CMR, then we may consider ICD. But if there is no LGE on CMR, then ICD is contraindicated. So it's pretty straightforward. This is the 2023 ESC guideline for prevention of SCD in HOCM. It's extensive, but most important here is the primary prevention. So it says implantation of an ICD is recommended in patients who have survived a cardiac arrest due to VT or VFib, or who have spontaneous sustained ventricular tachycardia with hemodynamic compromise. This is a class 1 recommendation. So this is for secondary prevention. For primary prevention, there's the risk, the HCM risk, sudden cardiac death calculator. It is recommended as a method of estimating the risk of sudden cardiac death at 5 years in patients more than 16 years of age. So if they fulfill the criteria, then ICD is indicated. It's a class 1 recommendation. So there are other aspects of the ESC guideline that is a bit cumbersome, but maybe we can go through them individually. Differential diagnosis of HCM, hypertensive heart disease, one of the most common differentials. Then athlete's heart, aortic stenosis, can be valvular, subvalvular. Then other infiltrative heart diseases, sarcoidosis, amyloidosis, depending on where the infiltration is, can also present similar to hypertrophic cardiomyopathy. A frequent question may be to distinguish between HCM and athlete's heart, which is a close differential. So patients that have the athlete's heart usually have sinus bradycardia, increased QRS voltage, tall peaked T wave, J point elevation, and U waves may be present. However, for those that have HCM, you may see pathological T waves, left axis deviation, and T wave inversions in the precordial leads. Left ventricular thickness rarely exceeds 15 millimeters in those that have athlete's heart, while in those that have Wacp, they have LV thickness of more than 15. LV cavity is larger or normal in athlete's heart, and the cavity is smaller in Wacp. Importantly, there's no demonstration of LGE on CMR, while in Wacp there is demonstration of LGE on CMR. So the summary to management. So these patients can present with any of these features. So to prevent any of these clinical profiles and manage each of them, so we prevent sudden cardiac death. We do a risk stratification, like we mentioned earlier, and to see if the patient qualifies for patients that have progressive heart failure with the obstructive mavacamten, sorry, then surgical myomectomy and alcohol septal ablation are also an option. So these are all things that we discussed earlier. For patients that have progressive heart failure, non-obstructive type, we follow the pattern, and remember that EF of less than 50 is considered as HREF, heart failure with reduced ejection fraction. And that is also categorized as end-stage HCM. Then for atrial fibrillation, we control rate and rhythm, and also we start anticoagulation for prevention of stroke. Genetic screening for HCM in first degree and other close family relatives is a recommended strategy. The preferred initial approach relies on non-invasive imaging technique, like we mentioned in the other charts, where we said this patient should undergo ECG, echo, cardiac CMR first, the non-invasives. And then if there are features suggestive of Wacp and with a family history, then this patient can go for genetics screening. Genetic testing is recommended in families that have identified pathogenic variant in the proband. The proband is the first family member that presents with the genetic disease, or proband has the pathogenic members can now go for genetic testing. Families and genetic counseling should be offered in all patients and first degree relatives. Genetic counseling is quite important in this situation because some of these genes are transferred to offsprings, even if the parents are not symptomatic, or if the parents do not even have LVH, the children may have the genes and they may present with features of HCM. So it's quite important that these individuals go through genetic counseling if they test positive for the gene. And always remember that only 30% of these patients have a positive genetic test. Finally, a take-home message, some take-home messages, sorry. HCM is more common than previously thought and typically require advanced management as compared with the other causes of heart failure. Symptom management, identification, prevention, disease-related complications such as sudden cardiac death, heart failure, stroke are cornerstone to management of HCM. Genetic testing should be performed in patients with HCM and may influence risk stratification and management. And finally, mavacamten should be considered in patients with HCM, and left ventricular outflow tract obstruction who remain symptomatic despite optimal medical therapy. And something I forgot to add in the slides is athletes and HCM. So there are different guidelines. I think the ACC recommends that these athletes should choose those that are having highly competitive sports, and they have HCM. They should choose whether or not to participate. While some of the guidelines say that if these patients actually have HCM, then they are not allowed to participate in highly competitive sports if they have an ICD. So thank you very much for your attention.
Thank you so much, Dr. Aminatu, for that brilliant presentation. Wow, thank you. Very detailed. Please, the floor is open for questions and contributions. We can unmute our mic or raise our hands to speak. The floor is open. Those going for exams and others. Dr. Adeanju, what do you have to say?
Thank you so much, Chief Okope. Thank you, Chief Aminatu. It was a fantastic presentation. I think it's a summary of everything that we will need to know. Thank you, sir. I don't really have much to say.
Right. Until what do you... Thank you so much, Dr.
Yeah, thank you so much for the very comprehensive presentation. First, just a comment. So there can be variants of the hypertrophic cardiomyopathy. It's important that we take cognizance of the fact that you can have the apical variant of hypertrophic cardiomyopathy. And when you're doing echoes for such patients, they will have obstruction, but their obstruction will not be LVOT obstruction. Instead, they will have a mid-cavity obstruction. So you find a high gradient around the mid-left ventricular cavity area. So if you are just concentrating looking for LVOT, you might miss that. So we should be cognizant that there could be variants to the hypertrophy. And the epic variant is another form of hypertrophic cardiomyopathy. And then if you could probably explain the pulsus bisferens in hypertrophic obstructive cardiomyopathy, if you could explain the mechanism for that to get clear to us. And then finally, is there any place for cardiac pacing as a treatment for obstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy?
Dr. Aminatu.
Thank you, Dr. Conte, for the contribution. I remember last year we made this contribution, and I was the one that was presenting something, and I didn't even mention this mid-cavity obstruction. You said it clearly. Thank you. The pulse bisferens, yes. I think the mechanism behind it is the systolic anterior motion of the anterior mitral valve leaflet. So when there is during contraction, during systole, the first ejection of blood out of the LVOT, then followed by obstruction of the anterior mitral valve, that is the systolic anterior motion. That is what causes the second pulse, that is the pulsus bisferens. I don't know whether I explained it properly or you can contribute more. And I didn't come across role of ICD in HCM. Pacing in HCM, not ICD.
Dr. Conte, is it the pacing after the ablation or pacing as a way of treatment? What are you trying to say?
So I think in the guidelines, so mentioned that in patients who have obstructive symptoms of obstruction, when they have hypertrophic obstructive cardiomyopathy, that is refractory to medical therapy, and they have contraindication to either surgical or interventional septal ablation. Then those patients, you can do pacing to sort of relieve the obstruction. So the kind of pacing you do, you increase the atrioventricular delay and allow adequate diastolic filling of the ventricle. You know, once you get better filling of the ventricle, you relieve, you know, the obstruction of the LVOT. So in patients who are refractory to medical therapy and they have contraindication to both surgical or interventional septal ablation therapy, then you can consider cardiac pacing with increased atrioventricular delay as a sort of palliative option for such patients. Thank you.
Wow, thank you so much. Any further contribution, Dr.?
I don't know, he didn't explain the pulsus difference, if he has more addition to that.
No, I think you said it. So the first pulse is when early in because usually when you look at the cardiac cycle, the SAM happens after opening of the aortic valve. So you feel the first pulse, and then the SAM happens, and then you have some amount of obstruction. So, and then it picks up again. That's how you get the double peak, giving you the pulses experience. So you said it correctly.
Okay, thank you so much, Dr. Rukaya.
Thank you, Chief Ukofi, and Dr. Ibna, thank you for the very concise and informative presentation. I just wanted to get a clarification. Okay, you've taken down the slides with you. With some of the epidemiology, I think you mentioned that it is the #1 cause of sudden cardiac death in adults. Now, I wanted to clarify, did you mean young adults or maybe adults in athletics or sports, or adults in general? Because I think what the general knowledge is that ischemic heart disease generally, you know, is the more common cause of sudden cardiac death in adults, but in young adults, especially previously healthy young adults who just have sudden death, usually during athletic activity, then HCM is the #1 cause there. So if you could clarify that. Then my network was really crazy. So I don't know if perhaps you mentioned the different, like as a rider to what Dr. Conte said, those with apical or I think asymmetrical septals, you know, they might have mid-cavity obstruction or whatever. So I don't know if you mentioned the different patterns that are possible, i.e., you know, the common one, the sigmoidal with the septum, part of the septum just near the LVOT versus mid-cavity versus apical. And I think there's one that is called neutral also, such that there's a more diffuse hypertrophy. But in general, like you mentioned, why it is thought to be that common is, you know, majority of patients are asymptomatic and without consequence. So that 1 in 500 is really pretty common. You know, I think that's even more common than DCM, but majority do not have any clinical, you know, manifestations or consequences. And the additional challenge with the genetic screening vis-a-vis, you know, how common it is like you mentioned, just 30% have a genetic abnormality. So should genetic screening be offered, there should be adequate genetic counseling, because if you find a mutation, so what? You know, if you find a mutation in just a random person, so it has to be like the people that it's offered to have to be selected well. So like you said, if there's a pro band, that's a person who has HCM and then has the mutation, then that makes sense to screen relatives, but not just like, I hope you get what I mean. So it has to be coupled with genetic counseling, and like the patient selection needs to be done well, because many of the mutations would not result in a HCM, or the person could have a HCM without the genetic mutation.
Thank you, Dr. Rukaya, for those contributions. You talked about it being the commonest cause of sudden death. Yes, in young adults. is the commonest cause of death in the young, sudden cardiac death in the young. And
Yes,
it is also the commonest. Sorry?
If you could just put the young on the slide so that.
Okay,
it's
no problem.
Thank you.
And it's also the commonest cause of sudden death in athletes. Actually, about 36% cause. The other causes are quite not common, but HCM is most common.
Yes, exactly.
Hello?
So if you could add that to the slides, that would be helpful. Thank you.
Hello? Hello?
We can hear you, Chief.
Yeah, thank you for the presentation. So how do you define dynamic LVOT in terms of pressure gradient and then normal LVOT, dynamic LVOT?
Chief, maybe somebody can help me with that. I don't know if there's any particular definition in terms of pressure gradient. I didn't come across it.
Well, I know of the pressure gradient, the range of greater than 50 mm, and then with dynamic maneuver, talk of the Vassava and the maneuver and the squatting too, which decreases the preload and thereby increasing the intensity of the murmur. Thank you.
Okay.
Hello. Hello, Aminatu. Good evening. Good evening, Chief Okopi. Good evening, everybody.
Good evening, Chief.
Yes, I just have a few concerns. And in the slide, it talked about echocardiography. It said that the left ventricular thickness that is above 1.5 cm or rather 15 mm should make us think of HCM. And I was wondering what happens in a situation where we have pressure overload like chronic aortic stenosis. So we almost see such things almost weekly on echo. How do we distinguish chronic pressure overload from ACM, where you don't necessarily need to have a peculiar septal hypertrophy to make that diagnosis, like chronic severe systemic hypertension or aortic chronic aortic severe aortic stenosis? That's point number one. Point number two. Now, even though it is a new drug, but who knows whether our examiners are excited about it? This is a new drug called the amacanta. What is the long-term effect? Does it prolong life? Does it just relieve symptoms? What is the long-term effect like in the treatment of this hokum? Thank you. Hello,
Okay.
am I still audible?
Yes, sir.
All right, thank you, ma'am.
Hello,
Thank
can you hear me?
Very well, ma'am. Yes, ma'am.
Okay. So the first question was regarding the echo findings.
Yes.
Okay, so it's not just finding based on what I saw in the diagnostic criteria or for making if you are making diagnosis for HCM, it's not just the thickness of the septum greater than 15 that makes the diagnosis. There are other features. That's why we have the differential diagnosis, because even some patients that have like you mentioned, aortic stenosis, or patients that have hypertensive heart disease, they might have a thickened septum. But what is peculiar for HCM is the fact that it's usually asymmetrical, and the cavity is smaller. unlike for maybe for patients that have athlete's heart or so on. And then if it is aortic stenosis, you also see the aortic valve and examine it while doing an echo. The pressure gradient is one of the similarities that both aortic stenosis and HUCOM have, where there is increased pressure gradient. But just an interventricular septum of more than 15 is not alone to say that the patient has HUCOM. Other echo features will contribute to that. I don't know if that is sufficient for you. Then you mentioned the issue of mavacamten, right? I think we discussed mavacamten.
Yes.
Yes. So mavacamten, like I mentioned, I don't know whether you remember in the discussion, it improves symptoms, reduction in ventricular outflow tract gradient, improves exercise capacity and symptoms. But I haven't come across, I know it's a new drug, but when I was reading about it, I didn't come across anything about long-term outcome or reversibility of this hypertrophy. It's just for reduction of symptoms and improvement in quality of life. That's just it. And then the circulating biomarkers were found to be reduced while using the drug.
Oh, that's great. Thank you very much.
Yes,
All right, thank you.
sorry. I think Dr. Sawa Francis mentioned something also, something really important. He said, please note that the condition for diagnosis of HCM is that the findings of thickened septum must not be explained by abnormal loading conditions, which is true. I forgot to mention that. So we have to consider all other options before we consider HUCOM as the cause of thickened interventricular septum. Then we can go for other diagnostic tests like CMR, and then consider the patient for genetic testing. Thank you, Dr. Francis.
All right, thank you so much. I think some persons made some contributions on the chat box. Dr. Olalekon is asking you, that should be part of your slides. Probably you can.
With abnormal blood pressure response to exercise on stress testing, then people with a previous history of cardiac arrest or non-sustained VTs. Okay, so there are other newer risk calculators that put some of these factors together, okay, and now determine whether the patient will require an ICD or not. So most times there are all these electronic calculators in some of these apps that are also used to, if it's above a certain threshold, patients will have an ICD. If it's below that, patients will not require an ICD. That's just what I wanted to say. Thank you.
Thank you for the contribution. Dr. Chineme, Dr. Chineme, when are you giving us the right heart catheterization?
Hello, good evening, Chief.
Yeah.
Why you stay so away?
Oh, okay, we want you tomorrow by His grace.
Chief, let's do Friday because you already called things for tomorrow. So I was like, okay, let me just let it be.
All right, Friday.
Thank you.
Yeah, Friday. Okay. Just before Dr. Chuka and Dr. Ejik comes up, I want to encourage those going for exam to pay keen attention. Ajayi will bear us witness. It seems there is one cardiomyopathy that they bring for the past 3 exams. And we were just focused on amyloidosis and a couple of high falutin stuff, and they brought back ARVC for us. And I'm suspecting, because of the loads of questions we saw in MCQ from HCM, it might come out in the oral. So please pay keen attention to this, so that in case it comes out, you have a smooth sail talking. So let me welcome Dr. AG for his contribution and question.
So, not much. It was a great presentation. I just want to make a brief comment on the markers of risk for sudden cardiac death in HCM. You mentioned a couple, then there's one that you left out: abnormal blood pressure response to exercise. And that takes me back to your investigations where you left out exercise testing. Because during exercise testing, you're going to assess the functional capacity and then the blood pressure response to exercise. And when, like I said, if you get the blood pressure response, that is a major recognized risk marker for sudden cardiac death. I think that's basically what I have to add.
Thank you so much, Dr. G, for staying this long. I know you're very busy. And then we have Dr. Chuka. Dr. Chuka, please, any contribution?
Can you hear me?
Yes, sir, we can hear you. Go ahead. Yes, sir.
The presentation was quite on point and covered all the things that need to be remembered. Dr. did a very good job, and also the other person that contributed to added something that were missed out. I think basically the thing that should be remembered are being touched. Just I hope that we all will remember to maybe just take a look at it later on before the exam, because I think it covers most of them that need to be looked at. It was a good presentation.
Thank you so much, Dr. Chuka, for always being around. Thank you for staying this long. It's always nice to have you guys around. I would advise that we'll have an in-house meeting for those going for exam on Sunday evening or Monday to discuss the whole scenario about the exam. So please prepare for that session. And just to inform Dr. G, Dr. Chuka, please, we would love you to be in that particular meeting so that we can give the final guides for those going for exams. Thank you again for being around this time. Okay, I will privately let you guys know when we'll be having that session. It's either going to be Sunday evening or Monday evening.
Okay,
yes, sir. Thank you so much, sir. Where our target this session, for this exam is 100% success, and so far the speed, the coverage has been nice. So they will just need that final experience through the exam beyond stuff. You can have all the stuff and still go and not come out good from the exam. So please, those going for exam, don't miss that session. It's one of the most helpful sessions going for the exam. In the absence of any other contribution or question, tomorrow we'll be taking fetal circulation, and we're taking 2 presentations tomorrow. I'll paste the topics. I spoke to Dr. Naman. She said she's in cardiology call this week, and she was supposed to take cardiac transplant. So she's pleading if she can take it on Sunday or Monday. But I told her it's too close to the exam. So we're still discussing. If she's available, we'll take it on Friday. And just the way Dr. Chineme said, she'll be taking the right heart catheterization for us on Friday. So we have loads of topics to take from now till Friday. Please, Dr. G and Dr. Chuka, I'll be so glad to have you guys all through this time. It's just close to the exam so that we can throw in some guides for those going for exam. So in the absence of anything, I'll hand over the class to Dr. Uzoki Cyril, the class rep. Thank you, sir.
Thank you, Chief Okupi. Thank you, all the seniors in the house, Chief Onyema, Chief IG. I don't know if Prof is still around. Hello, Prof. Okay, Prof doesn't seem to be still around again. Adeyanju. I don't know. I think final announcement has already been made about the topics for tomorrow to be pasted later. That is done. I think we'll naturally come to the end of this session. Adeyanju, what do you think?
I agree with you, sir. Please go ahead, sir. Thank you.
Thank you, everybody, and good night.